Okay, so sorry about that. Just had almost a little fire, but so Gigi was laying on top of some blankets and had my little um, hotspot or whatever you call it, the little Verizon jetpack, um, folded up in the blankets, and it overheated, and I guess it was keeping her very nice and toasty, and it melted the bottom of the little jetpack and shut down, and I had to wait for it to cool off, and luckily it came back on. And this is like the 10th time this has happened to this stupid box, or I've had to get a new one. So I'm not sure where it cut me off. It's downloading my previous recording right now. Apologize about that, but we are almost done. So hopefully you heard what I was saying about respiratory distress syndrome in the newborn happens within the first 24 hours, and we cure that by administering surfactant via an ET tube into the lungs. We bag some surfactant into the lungs and hopefully are able to extubate that patient pretty quickly after that. So our last topic is asthma. And Ms. Petchak has a lot of experience with taking care of kids in her clinic with asthma, and she has years of pediatric experience under her belt as a nurse practitioner. And I encouraged her to review asthma with you guys. So if you have any questions related to this topic, she is a good resource for you. But asthma is close to my heart because I have taken care of children who, in our area of Louisiana and all throughout Louisiana, there are such disparities in healthcare, in particularly with some of our lower socioeconomic areas and the families who have limited access, limited transportation, limited funds, whatever it may be. So children with asthma is a deadly disease if it is not properly managed. And I have taken care of brain dead children who died simply because they could not breathe and they did not have the medications that they needed, or parents who understood the consequences, the potential consequences of asthma. Maybe it was an education issue. I don't know what the issue was, but it makes my stomach hurt to think of a child who is unable to breathe on a regular basis and they don't have the medications that they need to help them survive. So it's something that just eats at me, and I want to fix it, and I don't know how. So I know this is difficult to see, but I've given you a few links. So if we click here, let's just see where it takes us. I know some of these dates say 2011, etc. But that's okay, because this will take you to the most updated website, the Louisiana DHH website, that gives you the latest statistics on asthma in our state. If my poor little internet will allow us to pull that up. So yes, so if you click on that link, here we have, let me make this a little bigger, the Louisiana Asthma Medical Burden Fact Sheet, and this is the most updated sheet that was available on the website. And it breaks it down by parish, and it's amazing to me that there's such a difference between Bossier and Caddo, but you know, you can take all of this with a grain of salt. This is the age-adjusted hospitalization rate from 2005 to 2009. And you can see that asthma hospitalizations rate per 100,000 patients. We have, on average, 145 people out of every 100,000 were hospitalized, Louisiana residents. And we had the highest rates of hospitalization, up to almost 500 per 100,000. That's half, right? Maybe not, no, it's not. Oh my gosh, I don't pay attention to my math. Be quiet, Stephen, both of the Stephens. Anyway, so we had the largest rate of hospitalizations when this data was gathered in Bossier Parish, and then we can see more high. There are plenty of parishes that have way too many when you compare it to the national average. And it says also children younger than 5 had the highest hospitalization rate. And the child that comes to my mind that broke my heart the most was around 5 or 6 years old. And the bus driver came to the hospital just beside herself in tears and crying, saying, every day that child would get on the bus and I knew she shouldn't be here. She could not breathe. And I would ask her, do you have your inhaler? Did you take your medicine? This and that. And that child took her last breath one day on the school bus, And they were rural. And by the time they got her help, the EMS arrived and they established an airway for her. She was brain dead. And, the bus driver saw it, but for whatever reason, she did not have what she needed to survive. Children aged 10 and younger constitute over 50% of the state's asthma recipients and almost half of our asthma expenses. So children younger than 5, children younger than 10. And then again, adults, once they are over the age of 30, the rates of hospitalization go up. Now, here is where I really get bothered. Blacks are almost 4 times as likely to have had at least one ER visit due to asthma in a year as compared to whites. Now, why is that? Why is that? So all I can tell you from what I understand is that when an African-American family with, statistically, fewer resources, whether it's a primary care provider, they see somebody different every time they go to the doctor. They don't get to go to the doctor as much because they have transportation issues, that they have to miss work, they have whatever it may be. It takes, due to either their insurance, lack of insurance, or for whatever reason, these families end up in the ER to be treated for their asthma. Now, is that because they wait until the child is so sick that they have to come to the ER? Or is it because they don't have a primary care physician? Because it's not easy when you are Medicaid dependent and have to, just wait in line for whoever can see you that day to get good follow-up and to have consistent care. Is it just easier to go to the ER as their primary care? It's not right, but it's a system error, not necessarily a human error or the fault of the family. It's the system. That's what I blame. On average, the white families have the health insurance that allows them to have consistent primary care. And I'm not saying that applies across the board, but I'm saying it's a fact. Our poor citizens in the state of Louisiana tend to be African American. The lower socioeconomic families also tend to be less educated or have a decreased health literacy. But I really think overall it has to do with access, whether it's financial, transportation, medication, whatever it may be. The overwhelming burden on these families it's just the way that it is. And these kids are falling cracks, and whose fault is it? I don't know. It's screwed up and it upsets me and I want to fix it. Have I said that once already? Whites are significantly more likely to have had an asthma checkup in the last year as compared to blacks. So for these families who do have poor control over their asthma, it's not properly managed, it's very difficult to manage your child's asthma and stay on top of it with the proper medications. And every time a kid gets sick, then they kind of backtrack and you have to start all over again or increase the dose of steroids or this or that if you don't have primary care or you don't have easy access to consistent primary care. In 2007, there were approximately 42 asthma-related deaths in Louisiana. I feel like, honestly, that number is probably higher. Maybe they all didn't die, but I'm telling you, the admissions are out of control. And then as far as the money that Louisiana spent on asthma recipients, I really don't care about, because who cares? I don't care. That's not my problem. I mean, I'm sure it is. I know it's all related, but it's just like, I'm not trying to solve the financial problems. I just want to get the kids their dadgum medicine. So, and it breaks it down by, this is a lot about finances, but age, 0 to 10, the number of recipients, and this is talking about Medicaid recipients related to asthma visits, asthma-related visits. You can see that that population from 0 to 10 had the most claims. Gender, it's pretty equal, male and female. But then race-wise, we had more African Americans than we did Caucasians. So anyway, that is one example of what you can find on these links here. So there's an educational PDF that we can give to our families. What happens during an asthma attack is another one, and a way to take control of your asthma. So the DHH website, if you happen to work in a healthcare setting where you have an opportunity to educate, please know your resources. The Louisiana DHH website has these resources, just like the CDC has resources that are meant to help families know what to do and where to go for assistance. But we're that link. When we have them in our facility, you know, that's when, if instead of just griping at the nurse's station about how the families aren't staying on top of their asthma and that their asthma is poorly controlled, how about, you know, making that appointment with the pulmonologist for the third time? Maybe, yeah, well, they're embarrassed to call back because the last 2 appointments, they were no-shows. But does anyone stop and ask why they were no-shows and what happened that made it difficult or impossible for them to, I'm not gonna be able to pull this one up right now. Let's not stress my poor little internet out more than it already is. Does anyone stop and ask and try to help? You know, I just, please guys, go and fix it. Figure out a solution. So that is my challenge for you, is to solve the healthcare crisis for children in Louisiana. Please click on these links and read about it. A lot of the education on this link, and this link will correlate with what we're talking about in your textbook and help you on an exam. Page 1057 is an example of how this information correlates with your textbook. On page 1057, it points out that the incidence is higher in 10 to 7, and remember, this textbook is written for the United States, the general population, not just Louisiana. The incidence is higher in 10 to 17-year-olds, African Americans, poverty-stricken areas, urban areas, and those that are exposed to frequent triggers. For example, Katrina hits, growing in all of those houses down there, black mold and different types of mold. All the families do not have the finances to strip out the walls and clean it all up. You know, there are plenty of people still living in substandard housing all throughout the state from flooding or whatever it may be. And you know, maybe they weren't flooded. Maybe it's just poor conditions, poor sanitary conditions. Do you know one of the main triggers for asthma is cockroach feces? I mean, don't lie and say you haven't seen a roach in your house. We've all got them in the South, okay? We've all got them. You can call them water bugs if you want to, but they all poop and they are triggers. So if that kind of stuff isn't controlled as best, you know, to the best extent possible, and that's that kid's trigger, then that's a problem. But oftentimes it's an environmental issue. So what is the pathophysiology of asthma? Page 1058 has the patho box. Please review that. And we can see in this picture here that here we have our normal alveoli where the gas exchange occurs. And backtracking, when I talk about PEEP, positive end expiratory pressure, you can see in this image how even at end exhalation, when you have exhaled all the air in your lungs, you blew out all the air, these alveoli remain open. That is due to our innate PEEP, our physiologic PEEP of 4 to 6 that maintains alveolar recruitment. It keeps them open. When those alveoli collapse, it takes more effort to re-recruit them or open them. So anyway, so with asthma, we have a process that happens where there is inflammation that occurs due to the trigger. So here we see an inflammatory reaction right here, such as increased capillary permeability and histamine release. So we have our basophils at work here. So we have this inflammatory reaction that is happening. We have mucus that is being produced. The mucus glands hypersecrete. We have our basement membrane that is becoming thicker due to the inflammation. Mucous membranes are not only secreting, but they are also becoming inflamed and edematous. So we have all this swelling on the outside here, all this secreting. You know, when something becomes inflamed, it sets off a reaction, and that reaction causes damage. And then we have our bronchioles constricting, which restricts airflow. Our smooth muscles on the outside are constricting. Our alveoli are air trapping. That's why we have hyperinflation on X-ray when we're wheezing. So those pretty alveoli up here, you know, this is what it should look like. When we're dealing with inflamed lungs due to asthma, we have some alveoli that are trapping air that are like a balloon that's about to pop. And then we have other alveoli that are not getting enough air to keep them inflated, and they collapse. And it's just a scary, scary cycle, a scary feeling inside that child's lungs. So that's this process that is preventing gas exchange in a patient with asthma. There has been a study, and this is documented in your textbook. I think it's in your textbook. There was a 2014 article that identified rhinoenterovirus as being one of the leading pathogens in acute asthma exacerbations, bronchiolitis, and viral pneumonias. So rhinoenterovirus, we see it a lot in that one is contact, one is droplet. So when our patient comes in, we do a viral respiratory panel and they test positive for rhinoentero. If they have a history of asthma, that can put them in the hospital. Whereas if you don't, it might just give you, a runny nose. May end up with a little bronchitis or something, maybe a low-grade fever, headache, just flu-like cold symptoms. Or it could, rhinoentero could lead to the bronchiolitis or even a viral pneumonia. So this is the type of information here that you'll see on some of those handouts on that website. So asthma is a chronic lung disease characterized by acute episodes of coughing, wheezing, chest tightness, and shortness of breath, with the most common triggers as listed here. So anything from the smell of the air freshener in the bathroom could be a trigger. My son, when he was 3 or 4 years old, was crying and going crazy at Red Lobster. He was still so young that he went in the ladies' restroom with me, and he was having a cow saying he couldn't breathe, and it was an orange scented air freshener. And if he had asthma, that would put him in the hospital, just sent his little nose over the edge. Cold air, weather changes. So we had a child a couple semesters ago that was a big old boy, and he was African-American, had very good health care. He was lucky. He had an educated family, good job, had health insurance, had his pulmonologist that he saw on a regular basis, but it was on a day that it snowed, one of the rare snow days that we have around here. And he was so excited, he ran to the car when his mom came to pick him up from school. And by the next day, he was in the hospital. Tripod position, wheezing like crazy, and actually getting to the point where he was not having as much wheezing because his airways were clamping down so tight that there wasn't enough movement of air in his lungs, or airflow in the lungs, that to create the wheezing. So it could be, you know, an allergy, just some kind of irritant, cockroach dander, smoke. You know, nothing gets me more than an asthmatic patient and the room reeks of cigarette smoke. You know, a lot of times the parents will say, he came back from his dad's, or they came back from their mom's. This was their mom's weekend or their dad's weekend, and I know grandma smokes in that house all the time. Every time they come back, they get sick. But then also infections like rhinoenterovirus or the flu or any of those upper respiratory infections can be a trigger, and also physical exercise like running in cold weather. So the symptoms of asthma are caused by the airway swelling, the blocked airways due to the mucus and the swelling, the smooth muscle constriction, and increased responsiveness of the airways. They get twitchy. That's a word that you'll hear. The airways get twitchy. The triggers, yes, they vary among different people, but viral respiratory illnesses are the most frequent triggers in pediatrics. Do you hear me? Viral respiratory illnesses are the most frequent triggers in pediatrics. So based on what I was saying a while ago, you know, be sure that you are aware that no wheezing in a child can be a very ominous sign. When they were wheezing and they were in a lot of distress, they're still in distress, but all of a sudden the wheezing has greatly diminished. That is not a good thing. If overall they appear improved, and you know we've been treating their asthmatic episode, and the wheezing is getting better, that's different. But I'm talking about a kid that was wheezing, is in a lot of distress, and then you don't hear much wheezing an hour later. That could be because their airways are so constricted that the wheezes cannot be created anymore. And then the x-rays typically are normal with an asthma exacerbation unless it's caused by a type of pneumonia, but they can typically, they can appear normal other than that hyperinflation. So when I talked about the hyperinflation, that, remember, is expanding and taking up space in the chest cavity. So when they look at the x-rays, the radiologist can recognize that they are hyper expanded because they count too many ribs. They should only, you know, count like 8 or 9 ribs, but they can count 12. And that tells them that these alveoli are stretched beyond capacity and taking up space, and the chest wall cannot go back down to its regular size due to the air trapping. So some medications, please be familiar with these. I need you to know the difference in albuterol and ipratropium. Ipratropium, the other word for that is what? Ipratropium is Astrovent. So you may have heard the term duoneb, nebulizer and a duo. Duonebs are a combination of albuterol and Atrovent, okay? Albuterol is our rescue medication. This is our bronchodilator that works quickly. This is our rescue med. Atrovent is an anticholinergic. It does not work that quickly. It is not a rescue med, but we need to get it on board. It works as a bronchodilator if it is given in conjunction with albuterol. So oftentimes the patients will receive duonebs on a routine basis so that we can get that Atrovent on board to work in conjunction with the albuterol. So albuterol and humidified oxygen should be given to try to keep their SATs greater than 95. Some, you know, unless the physician is okay with, you know, sometimes they'll say, you know what, I'm good with 92 or greater. So whatever your protocol is or your order is, we need IV fluids typically to help support them. because it's difficult to drink and maintain hydration, and they probably have some, what do you call the other types of fluid loss? Anyway, also we need steroids, corticosteroids, inhaled steroids. These children almost always will receive an IV corticosteroid, such as Solumedrol, that's the trade name, also known as methylprednisolone. Methylprednisolone is the generic. That's our IV corticosteroid. And when you look in the drug guide, don't necessarily stop on the first indication, which says anti-inflammatory / immunosuppressant. Keep scrolling down, and there's a status asthmaticus dose of 0.5 per kilo, 1 per kilo. There's a range there. So that's what we will do in the hospital, and then they will probably be sent home on oral prednisone to get them over the hump of this recent spell. We'll be doing a chest x-ray on these kids, of course, as well, and providing oxygen as needed. I need you to know, oh wait, hang on. What would be an example of an inhaled steroid? So in addition to their albuterol and Atrovent, many of these children are on a drug at home and or in the hospital, such as Pulmicort. Pulmicort or beclomethasone, it's gosh, I don't want to spell it wrong, beclomethasone, I believe. Beclomethasone is an inhaled corticosteroid. So, you know, when you look in your drug guide under steroids, there are the IV systemic, IV, the other word for that is systemic, because you give Solumedrol and you can't control where it lands in the body, right? It's in the bloodstream, it goes everywhere, it's systemic, versus an inhaled corticosteroid like Pulmicort, and you're delivering the steroid directly to the lungs. And then there are also topical steroids that are listed in your drug guide. So Pulmicort would be an example of an inhaled, locally acting steroid versus methylprednisolone, aka Solumedrol, which is a systemic corticosteroid. I'm just trying to make you guys so smart. Okay, so I need you to know how to educate a patient, how to properly use a meter dose inhaler with a spacer. So an MDI stands for a meter dose inhaler, and we can attach that to a spacer. Some of you have gotten to administer an inhaled medication with a spacer in the hospital setting, or you may have one of these for yourself. It's not just for children. They recommend these for patients of all ages now. A spacer mainly, you know, by attaching the inhaler to this end, it just kind of slides in a slot right here at this end, and this end goes in the patient's mouth. We can give 2 puffs into the spacer, and the medicine just sits there, and the patient can inhale and exhale over a certain time period to make sure that they get the entire dose of medicine. So here we see, let's see, I guess I have a highlighter here, but I do here. So here we see that, what in the heck? Stop it, go away. I don't want text, I want a highlighter. Here we see, well, that doesn't work, does it? Oh my word, here we go, Amy. How about that? Here we see that a spacer increases the amount of medicine delivered directly to the airways, because they don't have to be coordinated with the puff, inhale. They can just puff, puff, and then breathe normally. It also helps prevent getting a yeast infection. It prevents yeast infections directly in the mouth from squirting that medicine, you know, just directly in the mouth. You've got a leeway here, and it reduces the amount of medicine that is swallowed, which minimizes side effects. So read all about administration of the medication with an MDI using a spacer. And I also need you to look on page 1059, box 45-2, at how to use a peak flow meter. This slide may be from a previous book because my notes are telling me that box 45-2, page 1059 is the most updated guide. I want you to study that, and it should basically follow these instructions here. But what is a peak flow meter? It is a device that we use to help track how well we are managing our asthma on a day-to-day basis. So when you read about it, take note of what time of day a child should use their peak flow meter to be consistent. Think of it as, you know, if you're tracking your blood pressure, you need to take it at the same times every day, right? So if you're tracking your measurements using a peak flow meter, you need to follow the recommendations and do it at the same time of day each day. And the patient will take a deep breath in and then blast that air out as hard and as fast as possible in a single blow. And then they're supposed to repeat and record their best reading, okay? So it will tell them, by using the peak flow meter, it will tell them their peak expiratory flow rates, and it lands in a color zone. Green is good. That's 80 to 100% of their personal best. So that means their asthma is under reasonably good control. If it lands in yellow, then we need to be careful. That signals caution. Asthma is not as well controlled as it could be, and if the child does not move out of this zone with the recommended treatment, then we need to let the doctor know. This can actually tell a patient that they are at risk, or they may be getting sick before they even realize that they have a problem. That's why it's so important to consistently use their peak flow meter so that they know, you know, am I having a good day today with my lungs, or are my lungs twitchy today? You know, they live with twitchy lungs, so they may not really appreciate those feelings of chest tightness when they're mild and those symptoms are mild. And then if it lands in the red, that's a medical alert. 50%, below 50% of their personal best, that represents severe airway narrowing is occurring, and the bronchodilator, the fast rescue bronchodilator, is indicated. So how do they know what to do if the child lands in yellow? So this is the goal. This is one of those things that is on the DHH website, and actually the child is supposed to have this turned in to the school. I don't know, I cannot tell you without communicating with a school nurse in our parishes how good the parents are at this, or how good the schools are at keeping track of this stuff. But we have instructions that the child and their doctor ought to, you know, go over these guidelines, and the doctor makes the plan with them. And the doctor would say something like, okay, if your numbers, here's your personal best number. If your numbers are here to here, 80 to 100% of whatever their personal best is, then this is what I want you to do. Keep using your medicine, your long-term medicine, like you always do, however many times a day it's ordered. And before you exercise or play sports, 20 minutes before, I want you to take 2 puffs of this medicine. If you're in the yellow, you may have been noticing some of these symptoms and your numbers are here. I want you to take this many puffs of your albuterol, your quick relief medicine. If that doesn't fix you and put you back in the green zone within this amount of time, then I want you to do this. Keep using your long-term. And you know, if you get worse or the medicine doesn't work, you need to call your doctor, especially if this is happening more than twice a week. And then the red, you know, that's a problem. Take this medicine and this medicine on your way to the ER. Okay? Page 1060, the second paragraph talks about how even with teaching, you finish the sentence. I want you to read page 1060. The second paragraph where it says, even with teaching. If we were face to face, I would have one of you read it out loud, because that's what it's all about. Even with teaching, what? You go read it. I'm leaving you with a cliffhanger. Understand the degrees of severity. There's a box on page 45.3. I'm sorry. There's a box labeled 45.3 that discusses the degrees of severity. Be familiar with that. And also, please understand your classes of medications, your short-acting bronchodilators versus your anticholinergics, your mast cell inhibitors versus your corticosteroids. You guys need to be familiar with those drugs. And that's it. Sorry for my Wi-Fi explosion, and I will get this posted. I hope tomorrow goes well for everyone. See you later.